Hi, everyone. Hi, everyone. It's Dr. Aurora. I'm one of the resident physicians working with the Rural and Community series through UNM's Department of Psychiatry. I hope that I'm able to start soon so that we can have the best of our time together. Angela, would you like me to wait for other people to join, or is this a good time?
No, ma'am, you can start whenever you like. If you want to wait a couple of minutes, we can do that, or we can start or we can start now.
Sure, sounds good. Thank you. All right. Some things, like I just said, one of the resident physicians working with UNM's Department of Psychiatry. My training includes lots of different neurological, psychosocial, and sociocultural aspects of psychiatry to be able to treat the person as a whole and not just their illness. Do not have any financial arrangements with the content during this presentation. And these views are views of that I have gained through different resources, and it does not include anything related to UNM's policies or positions. And some of the learning objectives that we'll be focusing on today include summarizing the clinical symptoms of psychosis, differentiating the causes and the diagnoses of psychoses. We'll talk more a little bit about that later on during this presentation, and analyzing the symptoms that may be related to medical illnesses, may be related to substance use, or even medications that people are on. So we can start by just talking a little bit about what psychosis is and the sort of presentations you may come across. Psychosis includes, positive symptoms, which are things that are there but should typically not be there. And it includes changes in thoughts and feelings that are added on to a person's experiences. Some of these include hallucinations that can be auditory, so people hearing voices, visual, people seeing things, olfactory, sometimes they begin to smell things that are not there, and tactile, that's when they feel that there's like stuff crawling on their arms. They may have those perceptual changes. As far as the delusions, we'll chat a little bit more about those here in a second, but just a quick overview, there's several sorts of delusions that a patient may present with. Some of them may or may not be related to a primary psychosis on its own versus a delusional disorder. Disorganization is disruption in daily activities of patients, including their difficulty with speech, difficulty in expressing emotions, difficulty in the behavior and the activities that may be happening around them as a result of this disruption. A bit more about the delusions. So, like I said, there's several different kinds. The erotomanic are when an individual believes that another person, somebody who's in a higher status than them, is in love with them or is infatuated by them. The grandiose delusions are the ones that a person may feel that they have inflated power, they have the status in society, they have the knowledge and the identity to be a really famous person in the society. Jealous delusions can be something that a person may believe that their significant other is unfaithful to them, even though they may not actually have any sort of evidence behind that. Persecutory delusions are ones when individuals may feel that they're being treated malevolently, whether they're being cheated on, conspired against, spied on, or poisoned by individuals in their environment, whether that's significant others, friends, family members, strangers. It includes all of the above. Somatic delusions are one that people can have a perception of physical changes. It can generally be associated with a medical condition, but we may not have any evidence of the reason for why they're feeling a certain sort of physical anomaly. And mixed delusions are typically includes one or more of the above that we just discussed. There's not one particular thing that predominates in individuals who have mixed delusions. Non-specified, it's like none of the above delusion categories are able to fit the person's perception of what they're experiencing. And, just a quick overview as well, delusions are strongly held beliefs that are inconsistent with a person's reality. They can be a part of an underlying psychotic illness, like we just spoke about the positive symptoms of psychosis, and it can be presenting with, for example, schizophrenia, or it can exist as its own entity, which is delusional disorder. So it can be delusions without the hallucinations or disorganization in their speech, behavior, emotion, and they do not cause significant impairment in their day-to-day functional lives. Some of the negative symptoms of psychosis are things that are taken away or reduced from a person that they typically would be okay with and would not have any issues with. Some of the ones that we can discuss are like blunted affect, which means that they are unable to express emotion, whether that's like through verbal expression and even their ability to show emotions through their facial expressions. Alogia comes with avoidance of conversation. They begin to reduce in quantity of words spoken and the quality of words spoken in conversation with individuals in their environment. Avolition is reduced motivation to engage in day-to-day activities such as self-care, work and school environments. They, if they're younger, they may start all of a sudden have difficulty with school and classes. They are failing classes. Older adults who may be working are all of a sudden fired because they're unable to keep up with their work demands. And asociality includes social withdrawal. So they may have just a few number of friends. They may not be interested in any relationships around them, including family members, friends. They don't want to have any sort of connection with coworkers if they are still working. And anhedonia is reduction in individuals' ability to enjoy experiences that were previously not impacted prior to the negative symptoms presentation they may have. And, as far as the negative symptoms, I'd like to talk a little bit more about. They can occur concurrently with positive symptoms that we spoke about in about 20% of people with schizophrenia. 60% of people typically have prominent clinically relevant negative symptoms that do need treatment. Negative symptoms can also occur in any time during the course of the illness that a person may have. They typically, the symptoms such as a social withdrawal are the ones that are most prominent, about in 48% of individuals. They may have emotional withdrawal, which is in about 42% of individuals. In poor rapport, so they're unable to keep up with the conversation, about 39% of individuals. One thing to keep in mind is that the negative symptoms where they're unable to engage with individuals around them, they're unable to show emotions in their life, they're unable to have a day-to-day routine that they used to be able to engage in without any issues in the past. These symptoms may not improve with treatment options, but typically what does improve is the positive symptoms. So positive symptoms including hallucinations, delusions, and the disorganization. Typically, those are the ones that respond to medication and treatment options. The negative symptoms take a longer course of treatment, including psychotherapy, as well as, of course, the medications that can facilitate the recovery process. In anybody who has a first episode of psychosis, negative symptoms occur in about 90% of patients. 35 to 70% of them continue to have long-term negative features despite the treatment, like we just discussed. Does anybody have any questions regarding that? All right. This includes another summary of the negative symptoms and more sort of explained version of what we just spoke about. So I won't spend too much time on this, but just recognizing that these are the things that maybe the first things that are noticed by family members, by friends, because a lot of times people who are having psychosis, they're unable to share their perceptual changes with others because of the stigma that comes with mental illness, that, oh, you know, there must be something wrong with me. How can I describe this to other people around me? So knowing that, a lot of times the first symptoms to consider are the negative symptoms that are noticeable by coworkers, family members, friends, teachers, significant others, that a person may not even realize that they're having. And the identification of these symptoms can, the earlier it's recognized, the better the long-term recovery and the treatment options can be for them. Now we can talk a little bit about where psychosis occurs. So there's several different dopamine pathways, and dopamine modulates brain functions such as our thoughts, our movement, our ability to get engaged in daily activities, motivation, ability to have interest and rewards based on our day-to-day activities, such as even walking and talking. Impairment of the function of the dopamine pathways is proposed to be the underlying characteristic of symptomatology of psychosis and why people present with the positive and negative symptoms. Now, there's several different ones. The most important ones that I like to chat about are the mesolimbic and the mesocortical. Mesolimbic is the one that's more included in the motivation and desire of a patient's ability to do daily activities, their ability to want to do something and actually enjoy that. The mesocortical pathway is the one that is involved in emotional expression. So as you may imagine, I'm gonna go to the next slide so I can talk a bit more. The hypothesis behind psychosis is that there's overactive dopamine pathway in one part of the brain, and there's low acting glutamate pathway in another part. So glutamate and dopamine systems play distinct roles in signaling of your brain and the neurons that make the brain function, contribute to daily ability for the brain to actually function normally. And these specific pathways, the pathophysiology is related for psychosis and issues with these pathways. So as we discussed, the dopamine is more involved in your daily movement, thoughts, interest, reward, activities, etc. But glutamate is an excitatory brain molecule, so it helps regulate the cell function in the brain. It helps regulate memory and learning in the brain. And most of this is done through one of the receptors in the brain called NMDA receptor. And as far as kind of looking into features of psychosis, it's proposed that there's high activity of dopamine 2 in the limbic area. So that's the mesolimbic pathway that we were discussing. That's in the nucleus accumbens of the brain. Now, just a quick overview. I don't want everybody to think, where are these? If you'd like to know further, I'd highly encourage looking them up, but these are just specific things to be mindful of, that mesolimbic is in a certain region of the brain and the activity is really high. Mesocortical is in an area called prefrontal cortex, and the activity there is low. Dopamine activity is low in that area, which ends up having negative symptoms. So the reduction in individuals' ability to engage in day-to-day activities, and such as expression of emotions, ability to do daily tasks, etc. And this just talking a bit more about the overactivity in the two pathways versus the low activity in one of them. So if anybody has any questions, I can help clarify or discuss a little bit more about. I can do that at this time. All right. One of the things that we tend to, as I spoke about earlier, is the stigma and cultural beliefs for prejudice reasons. It's just mental illness is just sometimes, in quotes, a psychiatric illness, and that actually really in the long term affects individuals' ability to be able to function in society, to be able to actually get the treatment that they need, because the stigma comes with a lot of negative associations and ends up having long-term effects on these individuals' lives who are having certain mental illness issues, specifically psychosis in general. I would like to highlight that psychosis on its own is an episode where an individual doesn't feel like they're part of their environment. And it can be due to many different reasons. It can be because of substance use. It can be because they are not getting enough sleep. It can be because of an underlying mental illness or other underlying medical conditions that can be associated with that. Now, schizophrenia, on the other side, is a long-term mental illness that impacts thoughts, behaviors, and emotions in individuals. So in order for people to be diagnosed with that, like I said, psychosis is a one episode where that may be happening, and schizophrenia is a long-term, like chronic, with numerous episodes that impact their daily functionality. As far as with schizophrenia, one of the things to recognize is that people must have several symptoms for at least 6 months in order to be able to diagnose with that. One of them have to be delusions, hallucinations, or disorganized speech, and the others have to be the negative symptoms that we discussed. I'll chat a little bit more about the underlying illnesses that are associated with mental illness. Now, when we think about mental illness, we automatically think that there's schizophrenia. And I think a lot of that has to do with our social media and movie industry, because there's only one prominent known diagnosis that tends to come up frequently. But in reality, there's actually numerous different diagnoses that are related to underlying psychosis and primary mental illness. I would like to focus that psychiatric illnesses occur due to several different things, such as genetic predisposition, specifically in schizophrenia and bipolar disorders, and the mood and personality of a patient. Psychiatric illnesses can also occur due to aging differences. As we get older, there may be perceptual changes in the brain. I'll chat a little bit more about that here in a few minutes. In addition to the social factors that accompany our daily life, right? The cultural background we belong to, our socioeconomic status, our medical conditions, our financial distress. Somebody may not have a good childhood experience and they had trauma as a result. And as well as, it's important to think about an individual's sexual orientation. If they feel a certain way, but society doesn't accept that, that can lead to a lot of traumatic experiences, which can then in turn be associated with a psychiatric illness. As far as the underlying psychoses and the illnesses, we chatted a bit about schizophrenia, but I'd like to again focus that people have to have 2 or more symptoms for 6 or more months. Now, one of these 2 symptoms, again, just a quick introduction to it, one of these symptoms have to be delusions, hallucinations, or the disorganization. And the other symptoms can be the negative symptoms that we spoke about. As far as the schizophreniform disorder, again, it has to be this, it has similar criteria for identification of the disorder. So 2 or more symptoms, the same ones that we just spoke about. One has to be delusion, hallucinations, or disorganization in their speech. Others can be the negative symptoms, but in schizophreniform, the timing is different. The symptoms are present for more than 1 month, but less than 6 months. In relation to that, there's brief psychotic disorder, and that includes individuals who have just 1 or more symptoms and they have no negative symptoms, so only positive symptoms of psychosis, including delusions, hallucinations, and disorganization. But for these people, these symptoms are present for more than 1 day, but less than 1 month. And eventually they return to their, functionality that existed prior to this one specific episode that they may have had. I know it can be confusing to be able to differentiate between these, but I wanted to make sure that I discuss them so that we're aware that it's not just one specific illness that may be happening in a person. It's based on their duration of symptoms, the type of symptoms, the associated other things that may occur with it. We spoke about delusional disorder earlier, that it causes delusions such as the persecutory, the somatic, the erotomanic, lots of different delusions that do not cause functional impairment and do not have any hallucinations or the disorganization in their behavior. As far as schizotypal personality disorder, this includes individuals who may have odd magical beliefs with lots of bizarre thinking ideas. They may be having like social anxiety, and they may be paranoid and can stop interacting with individuals around them. They may lack close contacts. They may begin to start dressing in a really eccentric manner that wasn't there before. They may feel that they're getting sort of messages from TV or the radio around them, or that they have special powers that other people don't, like they can communicate with others to telepathic avenues. And superstitiousness is one of the other prominent features of somebody who has schizotypal personality disorders. So you can imagine how it may be difficult to differentiate schizotypal personality from schizophrenia. But one thing to remember is that the schizophrenia, again, long-term chronic functional impairment, whereas in schizotypal personality disorder, these symptoms can be present for a time period and may resolve as a result of a treatment, but not always. That's important to remember. A lot of people find it interesting to know that major depressive disorder can also present with psychotic features. And this happens when their mood disturbance, so their depressive symptoms, because it's major depressive disorder, happens to be accompanied by delusions, hallucinations, or both. They tend to have psychotic features that are likely treatment resistant. Specifically, if people have major depressive disorder with psychotic features, they may not be able to respond to lots of different treatments that they have had in the past. And this includes, several medication types, psychotherapy, but what's to consider is that their psychotic features don't resolve as a result of depression that they're having. So it needs to be addressed with psychiatric medications to tackle the psychotic symptoms that they may have. Bipolar disorder with psychotic features is another one of the underlying diagnoses that people do present with. And it includes, either manic episodes or depressive episodes, that are always present. So the mood symptoms are always there, mood meaning the manic features or depressive features. And they tend to have those that are always present, but the psychosis may or may not happen during each episode. As far as major neurocognitive disorder with behavioral disturbance, that tends to happen in individuals who have underlying like Alzheimer's disease. They may have traumatic brain injury. They may have Parkinson's disease. They may have other sort of dementia associated illnesses. But what happens is that as a result of having these underlying conditions, they present with behavioral issues such as violent tendencies that may be verbally or physically aggressive towards others around them, or they may present with new onset, never previously had it, but start having hallucinations and being paranoid that their family's out to get them. They may start breaking things around the house because they don't trust them anymore. And a lot of it has to do with the underlying cognitive impairment that they're suffering from. Does anybody have any questions regarding these?
Dr. Arora, I have a quick question in the chat from Angela. She's wondering how to differentiate audiovisual hallucinations due to psychosis from other diagnoses where audiovisual hallucinations are possible.
All right, let me open that really quick, just a second.
We also just had another one from Jacqueline as well.
Okay, sure. So that's something that, for Angela's question, like how to differentiate that these hallucinations are happening because of psychosis or they're happening because of other reasons. That's where, we have to kind of consider medical issues, and that's something I will be talking about here shortly. Medical issues and substance use related hallucinations are really frequent in individuals who come in with psychotic presentation. Now, it can be difficult to differentiate whether one is due to just a primary psychotic illness versus the other is due to a medical condition. Often people who do have psychosis also have like substance use. So in order for us to differentiate the two, which one it is, it may be that they have to be off of any substances for at least 6 months to recognize that the issue is the primary psychiatric illness and not another cause of it. There's medical workup that can be done to see if there's issues in their lab levels, their vitamin levels, their blood levels, lots of different issues if they have underlying liver disease, kidney disease. So once you kind of rule out a lot of other things, we also like to get information from family members, specifically for individuals like this, like the only person in the family who's had this. So maybe that they are doing substances that the family is not aware of. We have to recognize that those things are confidential, but always confirm the history with family. If somebody does have a family history of schizophrenia or bipolar disorder, there's a high prevalence of the illnesses also happening in other family members. Does that answer your question, Angela?
Yes, ma'am. Thank you. And I know that's some more information is coming up a little later, so I'll wait too.
Sure. If you have questions, please let me know. I'll be reading the next question. Jacqueline's question is, when it comes to major depressive disorder and bipolar disorder with psychotic features, are individuals prescribed antipsychotic medications for the rest of their life, as seen in primary psychotic disorders? So typically, I would say yes, they frequently have to, because if they're getting treatment for their primary disorder, whether that's depression or bipolar disorder, which has depression and manic features, they may only respond to treatment for those specific illnesses based on the treatment they're getting. So they may have depression that's resolved, they may have mania that's resolved because of the medications they got, but the psychotic features may not ever go away unless they're treated. For some people, you know, once they're on one medication, it tends to lessen the burden of the psychotic features that they're having. For some people, it takes several different medication types and trials and dosing to be able to determine which works best for them. So typically, yes, to answer your question, Jacqueline, they may have to be on a medication for a long term because the psychotic features can then recur in the future if they're not managed accordingly. All right. So next, I want to chat a bit more about medical causes of psychosis. And I know this has a lot of information on the slide, but just recognizing that there's a lot of medical conditions that do present with potential disturbances in your perception that can be just thought of as, you know, the stigma associated with it. Oh, well, it's just a psychiatric illness. This patient's just a psychiatric patient. And that's the approach that we don't want to take. It's this patient is presenting with a psychiatric issue, and we need to recognize and kind of determine what the cause is. And in order to do that, you know, there's lots of different lab works, and I'll chat a bit more about it here in a few minutes. But to consider some of the illnesses, there's thyroid issues. People who have low thyroid levels or high thyroid levels, they can also sometimes present with psychosis. And they can be either because their medications are not the right dosing that they're on, or they're getting too little or too much of medication. People who have liver disease can have perceptual issues. Something called cirrhosis happens in individuals who have long-term liver disease that can cause differences in their blood levels, causes something called encephalopathy, which is confusion in their thinking on a regular basis. And we see a lot of that happening in people who have hepatitis C, hepatitis B, people who have like long-term alcohol use, and even people who have just underlying liver disease because of genetic reasons. There's autoimmune diseases that can present with psychosis, such as lupus. It's interesting how sometimes the main presenting symptom of lupus before anybody has any sort of rashes is this new happening of psychosis that never happened before. And it doesn't happen that frequently, but it can happen. Also to consider that as people age, their body's metabolism changes. So as a result, the medication that they were previously on may not be medication that's enough for them to control their lupus. So as a result, they may start then having lupus kind of interact with their brain, and that ends up causing psychosis. Lupus is a condition where it's like autoimmune, your body kind of attacks itself, and the body attacking itself leads to impairment in lots of different organs, like your kidney, your heart, your just skin, your liver, your brain. So lots of different conditions such as lupus can present with psychosis. Lots of other neurological issues like multiple sclerosis, people who have brain tumors, Parkinson's disease. I would like to have a little bit more conversation about Parkinson's disease. What happens in Parkinson's disease is that people do not have enough dopamine. What happens in psychosis is that people have too much dopamine. So if you're treating Parkinson's disease with medications that increase their dopamine, sometimes it's too much medication, and that can result in psychosis features because you're giving them extra dopamine that they don't have anymore, and that can cause perceptual changes. So that's something to be mindful of. Their medications may need to be changed as a result. People who have Huntington's disease can have psychosis. People who have dementia, we spoke about that earlier, like Alzheimer's disease, they have like Lewy body dementia, which happens in individuals who start having like visual hallucinations. They start seeing things that are not there, but they also have underlying dementia or frontotemporal dementia that happens in individuals who may have, the underlying dementia in addition to a new onset of personality changes. They are like hyper oral, so they have like more oral activity. They may be hypersexual with the individual around them that previously were never like that. They have like all of a sudden personality change that the family doesn't recognize, and it's really worrisome. And of course, that can be also due to a lot of other medical issues, such as, the vitamin levels are off, or they're have too much sodium in their blood or too little calcium in their blood. So that's why a medical workup is important. Infectious reasons of psychosis can be due to lots of different reasons. That can be like meningitis in the brain. There can be sepsis in the whole body that then ends up causing psychosis. HIV, syphilis can cause it. Some diseases like Addison's disease, which is where your adrenal glands that sit on top of your kidneys are unable to function as they should. There can be because you have a thyroid storm, which is called thyroid toxicosis. You have like too much thyroid in your body, and that can happen often just briefly, or individuals who have long-term thyroid problems. And it can happen because they're taking the medication or they took too much medication. It can be due to, anybody who has a vascular event in the brain, such as a stroke, and that ends up causing difficulty for them to be able to talk. And that's Wernicke's aphasia. So that may be then associated with their ability to express emotion and later ability for the brain to function as it previously did. So the stroke where part of the brain didn't get enough blood, it starts kind of decaying and dying. And that brain region may be the brain region where dopamine's activity primarily lies, as we spoke about earlier. Lots of medications to consider. People who are on steroids can have psychosis. People who are on HIV medication, people who are taking medications for like malaria can have psychosis. People who have some medications like benzodiazepines, which is like Xanax, includes like lorazepam, includes diazepam. People who have those can also result in psychosis because of they're taking too much of that medication. Lots of toxic issues in the body, such as copper, iron, too much of them that get deposited in the body, lead poisoning, carbon monoxide poisoning, vitamin deficiencies, specifically considering the B1, B3, B12 in individuals who are elderly. I'll chat a bit more about that shortly. As far as psychosis due to substance use, substance-induced psychosis can exist concurrently with an underlying mental problem. And that can be, that's when it's difficult, like when Angela had asked that question, to kind of differentiate which is the primary reason if this person has never come to us before and now all of a sudden they are coming to the hospital, but they also have a positive urine drug screen. And it's hard to tell when they're younger. That's why they have to be off of substances for 6 months to be able to clarify whether or not it's a primary psychiatric illness. One thing to be mindful of, psychosis due to substance use can be either because they're intoxicated, they just did some of the substances, or that they're withdrawing from it. So either they'll be super anxious and verbally or physically aggressive or violent, with or without hallucinations or delusions, or they may just be calm and redirectable because they just did some of the substances. Causes to consider for substance use include like methamphetamine, cocaine, heroin, considering alcohol, both intoxication and withdrawal. Benzodiazepine withdrawal, so those are drugs like Xanax that we spoke about. Cannabis can cause psychosis, specifically higher content cannabis that's like synthetic, such as spice or the wax and dabs that people use in society. Hallucinogens like PCP, mushrooms, MDMA, they can also cause psychosis. One thing too I would mention is differentiating PCP from cocaine is both of them will present with really high heart rate, really high blood pressure, lots of sweating and anxiety. But PCP specifically present with people are actually seeing things. So visual hallucinations is associated with likely PCP intoxication if you happen to think that a person's using substances, but you cannot obtain a drug screen because they're too agitated in the moment. Ketamine, bath salts, and believe it or not, coffee can also cause psychosis. One total drink of, let's say, like a Folgers cup is about 80 milligrams of caffeine, and total daily recommended dose is 200 milligrams. If somebody has a Starbucks drink, that includes about 200 milligrams, which is your total daily dose. So if you're getting an extra shot in your Starbucks Frappuccino, then you can have like a really even higher level of caffeine intake, which can lead to stimulant kind of induced psychosis in some people. It doesn't happen in everybody, but it can happen in several individuals. And that includes like euphoria. They have like hyperactivity, where some people get really paranoid, and some people may have like altered sense of perception, and they may not like realize where they are. They're too activated by those substances. Now, I'd also like to mention that as far as considering age changes, elderly individuals are more vulnerable to substance-induced psychosis and the sort of perceptual changes that come as a result because of many comorbidities that they may be having. So if they have underlying like heart disease or liver disease, underlying dementia, they have certain medications that they're on, their body reacts to that differently because your metabolism changes. So even small quantity of like any substances or drugs in these individuals can have a significant impact. There's a question. All right. If there's any questions, please let me know. As far as discussing the medical workup of psychosis, there's we discussed earlier the sort of causes that happen. So this is just a highlight of things to consider. I won't go too much in depth because I'm sure a lot of individuals here may not be using the lab work or the studies, but just to be mindful of what to do for lab workup of psychosis based on what the patient comes in with, specifically, in the elderly patients. One of the most common reasons for psychosis in that age population is UTI. They may not have realized that they're having symptoms. So getting a urine test for them is really, really important. I'll go ahead and move forward. And if anybody has questions regarding this, we can come back to it. For others, management of psychiatric illnesses, first thing you should always do is having a verbal de-escalation. So always try to be attentive to them, not cause more disturbance in their environment than they already have. So such as using a quiet room, turn the lights off, let them rest, and don't interrupt if they're talking, right? They may not be able to discuss everything right away, so give them a period of silence if they need to. Acknowledge people who are discussing these things and their emotions. And sometimes it's hard for us to realize that if somebody's having sort of emotional reaction and they may be crying, our automatic response is, hey, look, I am trying not to make you cry, so why are you crying? You need to stop crying. But if you do that, then patients tend to be ambivalent towards any sort of therapeutic approach of any sort, whether that's like acutely or long-term treatment. So just some strategies to keep in mind. And I would also say medications are to be considered to calm them and not to sedate them, and to offer oral ways of medications before considering injection use, which may be needed in certain individuals. Or just sort of an approach to have for medication to treat psychosis, depending on what they're coming in with. So just in a brief sort of summary, I'd like to say that there is benzodiazepines that you do use for most of these. So benzodiazepines like lorazepam, which is Ativan, it is like fast acting. It kind of can help people get their agitation in control, which may be out of either due to underlying like substance intoxication, or maybe due to just underlying untreated psychiatric illness, or it may be due to their use of any sort of like alcohol even. So that we have to differentiate between that time. It can be difficult to determine whether or not to use like benzodiazepines in somebody who has like a depressant like alcohol in their system, because you don't know how much they have had. So in that situation, you may like prefer the medication haloperidol, which is a first generation typical antipsychotic medication, and it tends to work well in that population. One thing to be mindful of in the elderly is that they have different metabolisms and different ways of reacting to medication. So it's important to make sure that we don't make their cognitive status worse by giving them benzodiazepine unless it's really necessary. So in those individuals, like low dose psychiatric medication is warranted. Let me see, I think there's a question. Yeah, so there was a question regarding how to manage psychosis at like in the outpatient level in rural areas where there may not be resources, or there may not be sort of ideas about what to do in that situation, because people may have like I said, lack of resources, and may just think, oh well, this patient all needs to be hospitalized. That's not always true. There's lots of different things like I was just speaking about. So in individuals who are having like these presentations, if they're intoxicated, give them Ativan, just low dose. If they're having alcohol, you can give them the haloperidol, with or without the benzodiazepine, and Benadryl, which tends to counteract the side effects of the antipsychotic medication. So depending on what they're presenting with, being mindful of there's acute treatments that can help the patients and help them either calm down, help them in the moment to kind of take away the stress they're having, or often, they may be on certain types of drugs, or they may be withdrawing from something that you don't know about because you don't have a urine screen. So at that point, let them metabolize, let them take it easy. The typical medication of somebody who comes in like really agitated and is difficult to kind of take care of in like an outpatient clinic, you may offer them like an oral B52 is what we call it. So Benadryl 50, Haldol 5, and Ativan like 2 milligrams. You can offer them that. It doesn't have to be given an injection if they're able to, still kind of take it easy and like sit there and they have like somebody accompanying them to the clinic, you can use that. Or if they're really agitated and are not able to get control, then you can offer the injection, which can then you can observe them over time. As far as medication is not the only treatment as far as like considering long-term therapy in addition to medication is something important to consider. And I know it's difficult to hear when there's lack of resources in the community, kind of like what to do or who to refer them to for ongoing treatment options. I think that's where like a lot of our states kind of trying to address those things and having people join different echo sessions where they're able to bring patient presentations where they're unable to treat them appropriately. So I would encourage reaching out to UNM specifically to be able to get in touch with individuals who are experts in these background information to be able to get more help regarding the treatment options. But this is just a quick sort of management guideline. If anybody has questions, we can chat more about that. All right. So I want to do a quick case. I won't spend too much time on it, but this happened that, it was a patient who came into our UNM hospital. I was on another service at the time. I was working with the neurology team, and this patient is 39-year-old male, no prior psychiatric history that was given to us by family, has recent changes in behavior. He started to act irrationally. He was being hypersexual with his nieces. That was never prevalent before. There's question of substance use. His drug screen was negative. His family said that he hasn't used any, but one of his friends said that they saw him use something, and we don't know what that something was. So it was difficult to say whether or not he truly was any substances. As far as, doing the blood work, it was negative. His urine screen was negative. He had like no signs of stroke or brain tumors on brain imaging, no chest x-ray issues, but we still had to kind of consider, well, what to do, what's next. So at that point, we decided to do the spinal tap and analyze the spinal fluid. And a lot of things that tend to present with psychosis with the central nervous system and the brain issues, they take a little bit longer time to be able to result. So it's difficult to say, and everybody thought that this patient had a primary psychiatric illness, which given his age, it can happen later in life, but for males, typically like schizophrenia happens earlier, like late teens, early 20s. So that could be potential, but I wasn't convinced that that was the reason. So after several spinal taps and the analysis, one thing that came out to be was that was positive was NMDA, and I think we spoke about that earlier briefly. I mentioned NMDA. So it plays an important role in learning and memory. What happens is that there's a autoimmune condition where the body starts reacting to the NMDA receptors and ends up having disruption in normal brain signaling and cause swelling in the brain and lead to the psychiatric presentations. Typically, just a quick introduction, people may present with like flu-like symptoms, like fever, fatigue, and headaches initially, and then all of a sudden end up having like psychosis where they have delusions or auditory hallucinations. They have behavioral changes, such as in this patient who started being agitated, was confused, was acting differently than he ever had before. And then long-term, people can have like seizures. They can have kind of difficulty in regulating their behavior, their breathing pattern, because the heart rate, the blood pressure, the lungs, like lots of physiology changes. So it's not fully known, as far as like how to treat and or what causes the NMDA encephalitis. But what we do know is that it's an autoimmune condition, and there's lots of like environmental genetic factors that are likely triggering the disease susceptibility. There's just more like viral presentation than psychiatric presentation, then like long-term difficulty in managing your blood pressure, your breathing patterns. And in the chronic things, one thing to consider is that their executive functioning, their sleep changes that may have occurred as a result of this encephalitis, which is like a brain swelling essentially, ends up having long-term effects, and they may not be resolved. So it can take like quite a few like months to years to kind of come back to their functionality that they previously had. I won't go too much into this, but if anybody would like to know more about NMDA, the treatment options, give them steroids, but not too much steroids because that can worsen their psychosis. You have to do like plasma exchange, get their blood filtered and regulated. You may have to give them like IV infusion treatment, and long-term, like I said, the cognitive, behavioral, and memory problems can persist for quite some time. And here are some references that I use for this talk. And I appreciate everybody's time here. If anybody has specific questions, concerns, thoughts, ideas, I would definitely be open to conversation. I know we don't have too much time, but I hope we can answer a few questions. This is a lot of information all of a sudden that was kind of given to you guys, but I do want to say that psychosis in general is not just a reason for a mental health issue. It can be a lot of different problems. So having a non-judgmental, open-minded perspective on it can be really helpful for individuals, specifically because a lot of them tend to deal with on a regular basis, maybe interacting more with like social workers or caseworkers or therapists more than their primary psychiatric doctor or psychiatrist that they're seeing. So just having that perspective in mind that it's not just one or the other, there can be lots of reasons, can be essentially effective treatment, gives the treatment options and recovery options for people. And destigmatizing it is one of the important things to keep in mind. I think the slideshow also had this. I'm not sure if you guys need this, or I think Angela posted something in the chat for the QR code and the link. Yeah, I appreciate everybody's time, and if anybody has questions, you can definitely reach out to me. Angela does have my email. If you guys have questions regarding the talk, or if you have any feedback that you'd like to give to me, I would appreciate anything. If there's any clarifying questions that I can help answer at this time, I can definitely do that.
Yeah, thank you so much, Dr. Arora. I just want to make a quick announcement about CEs. You'll have to follow the link or use that QR code in order to complete a REDCap survey in order to receive your certificate. And it is your responsibility to save that certificate. I also wanted to just acknowledge the New Mexico Behavioral Health Collaborative and Human Services Department for sponsoring this talk. I also shared a link to the CBH listserv if you wanted to know about future presentations. And yeah, thank you again, Dr. Arora. This was fantastic.
Sure, you're welcome. I think there was a question in the chat. What drug is most used with psychosis and dementia related to violent behavior? So in individuals who have dementia, for violence, typically you can use a low dose, the haloperidol. So depending on the age of the patient, it can range from like 0.5 milligrams to 5 milligrams to be able to tackle the violent tendencies. Often in the elderly population, medication that is used is called olanzapine or Zydus, or Zyprexa is the other name. Zydus is the formulation that's the like disintegrating tablet. So it's sublingual type of medication that can also be used, but specifically for violence, haloperidol is the one on low doses for elderly individuals who may have cognitive impairment. That may be baseline for them. Yep. All right, well, I'll stay on for a few more minutes if anybody has questions that I can answer